Right, so welcome to everybody. I'm Claire Chilvers, trustee of MHR UK, and Mike took over from me as chair just over a year ago. It's great to see so many of you here today. It's really good. So this session is a bit different in that we're hearing from three of our MD Res scholars. So the MD Res is, well, it's a Doctor of Medicine MD degree by research at King's College London. And we're very proud to have been able to support a number of students going through this course. And they are young psychiatrists, and they're doing this course part-time, which is extremely demanding. So I think that we will make a start. Please keep to time, I'm going to say to the speakers, because otherwise we will suddenly be transported back into the plenary session. So first of all, I'd like to introduce Camilla Day. Let me see if I can find Camilla. Can I see her? Is she here? I can see Kate. Oh, there we are. Yes. Hello, Camilla. Yes. So Camilla is funded by one of our particular awards called the Tom Palmer Award, which was set up in his memory. And Camilla is a psychiatrist with a particular interest in psychotherapy and especially psychedelic research. And her research on self-compassion is being undertaken in the context of a clinical trial funded by the National Institute for Health Research, led by James Rucker, one of her supervisors who wasn't able to be with us today, sadly. And also Professor Alan Young. So Camilla, over to you.
I'm just trying to share my screen. If I go. Sorry about this. It was it's asking me to go to my my system preferences. It's saying open system preferences, go to security and privacy to grant access.
Can you not see share screen?
Yeah, yes, I'm pressing that and it's saying okay.
Camilla, I had this issue last time. Have you got a Mac?
Yes.
Yeah, so there's a button you can press which enables you to, you have to enter your password or something like that, which will allow you to then share the screen via Zoom. Have you got the little window which has popped up?
It's come up as a bunch of sort of desktop whiteboard.
Okay, so you need to choose the right document and then click share.
So there should be something which allows you to say.
And then it says allow Zoom to share your screen, open system preferences, security and privacy to grant access. So I open system preferences. Okay, here we go. No. Click. Okay, yeah. Thank you. Sorry, I think I was slightly panicking there. It was hard to think.
Yeah.
Okay, I think I have to come back in again. I'm just hi there.
You're
Okay.
back with
I'm sure that I have I'm sure I've done a presentation on this MacBook Pro on Zoom before, so I'm really sorry. I don't know what happened there.
Don't worry.
Okay, so so I'm going to finish at 12:15. So I'll just go through this a little bit quicker. Thank you everybody for your patience. So yeah, I'm Camilla. I'm a psychiatrist. I've worked for 10 years in Southeast London as a psychiatrist, and I've just finished my training, and I'm in the process, in fact, of applying for consultant psychiatry jobs. In fact, in eating disorders. But I'm doing my research in psilocybin assisted therapy in treatment-resistant depression. So as Claire said, my research is forming part of the aims of a feasibility study, a phase 2B study in psilocybin for treatment-resistant depression. This is a registered or protocol report that's been published for that, and this is funded by the NIHR, a grant that my supervisor James Rucker got, and I came to work with James Rucker because we worked together in the open label psilocybin study in Imperial in 2014 and 15, and we together guided quite a few of the participants in that trial, which showed very promising results. So my MD Res aims are, as Claire said, they involve sort of looking at the contextual factors of psilocybin. So what is part of the psychological mechanism of effect of psilocybin? There have been different conceptualizations, but from the work I did in Imperial and qualitative research I did, I'm interested in the idea of compassion. Do these psilocybin experiences help people to become more compassionate, in particular towards themselves? Although this is just probably one small thing, and actually the idea of compassion also is important, thinking about compassion for others and also receiving compassion from others, as Paul Gilbert talks about. So that's one thing I'm looking at. I'm also developing a what I'm calling a psychedelic compassion experience scale to try and quantify those experiences that people have that might lead to improvements in depression. And again, this is one way to conceptualize it that I think might be important within depression. There's been a lot of other ways as well. I'm also looking at the therapeutic relationship. How does someone's perception of how they feel with their guides, how does that affect the outcome? And that's via validated therapeutic relationship scales done by both the participants and the clinicians. So I'm just going to mainly focus on my qualitative work, which will underpin what I've just spoken about, but the two other main aims for my qualitative work. One is the optimization of the contextual factors. And then the second is to have a look at, does psilocybin assisted psychotherapy transform the life world, and particularly does it transform it more than placebo assisted psychotherapy? Because the trial which my study is situated in is a randomized placebo controlled trial. So we're giving psilocybin with psychological support to 30 individuals, and placebo with psychological support to another 30 individuals. There are obviously inherent problems with randomization with psychedelics. Obviously, it's basically impossible to keep blinding. So thinking about the optimization, so there's a basic assumption with psychedelics, with all psychedelics, that the setting is fundamental to the outcome. However, there's little research really to show the importance of this, and this is a really important idea that needs to be researched. And what my project really is mainly about is making sure that as psychedelics, if they do start to get rolled out, making sure that they are rolled out in a way that's safe, that's going to minimize any potential harms, and also really optimize the benefits. Because psychedelics are not just like any other medication that can be given, you give people a pill and they go away. The kind of the way psychedelics work is incredibly psychologically orientated, and the main risks from them are really potential psychological risks. Physiologically, they're incredibly safe. It's essentially impossible to physically overdose on psychedelics, but definitely psychologically there could be potential harms. For example, if you think back to the kind of experiments that the CIA did, they used to give people psychedelics without them knowing, and lo and behold, these people became very disorientated, paranoid, and even suicidal, and there were cases of suicide after this. So this, if you think about this is like a very bad setting in which to give psychedelics. So you're giving them for the wrong reason, trying to sort of experiment with people, and doing it in a way where people have no idea what's going on and are being actually intentionally misled. So if that's like the worst setting, what we're trying to do in terms of making a good setting is really the opposite of that, is helping people to feel safe, to really look into themselves, to find out more about what's going on with their depression, what are the factors that are keeping them depressed, and to help them to be empowered and to have more insight themselves, to come, to be able to then change their behavior to become less depressed. So that's sort of the optimization of contextual factors. The other thing that I'm very interested in is looking at the transformation of the life world. This comes out of a reading group that I've been facilitating for some years about phenomenology, and the main person who's really inspired me relating to this is Martin Heidegger, reading Being in Time. It's all about the idea, rather than the Cartesian idea that we're sort of separate objects, separate subjects and with objects. It's the idea that actually, in terms of our consciousness, and it's the idea that we are beings in a world, so that there's always a dynamic interplay between us and our context, between us and our world and the objects around us. And it's actually very hard to separate that. In a way, it's similar as well between the mind and the body, the idea that actually those are very connected, as Leila was talking. Husserl and Merleau-Ponty are other people that are quite important relating to that, but I'll move on. So I'm interested that mental health, the scales that we currently have, sort of think about mental health in a quantitative way. You have sort of more low mood or more kind of insomnia than the usual person. But there's an idea that actually in mental health conditions, the experience is qualitatively different. And this is why qualitative research is so important. And that experience of depression are not just, you're feeling more like that or less like that, but there's a real kind of profound strangeness to the experience, and also the idea of the loneliness and isolation from others, which is very important. So I'm sort of realizing I'm running out of time, so I'm just wondering how to just maybe, shall I just finish in 2 more minutes, Claire, or do you want me to?
Look, I think just go on and try and finish, and then we probably won't have questions at the end if we run out.
Okay.
Yeah.
Okay, thank you. So one of the reasons I'm interested in psychedelics and psilocybin is from the work I did at Imperial, that I saw that people really did have these sort of qualitative changes to their consciousness, that they had feelings of feeling more connected to themselves and others and the world around them, and a sort of feelings of acceptance relating to certain things that had happened to them. And I'm just going to kind of compare that to, this is a study, a qualitative study in 1,700 people who've used antidepressants. And it's interesting that they're kind of how they describe, 56% of them had a positive experience with antidepressants. And they sort of describe them as necessary, meeting social obligations, and it being a kind of treatment for disease. And then there are obviously a few, as we know, not everybody gets on with antidepressants. And some people, they're ineffective, and, a lot of people have side effects. So in terms of thinking about my qualitative work with psilocybin, what I'm aiming to show is actually, to document by interviewing specific subjects, what qualitative difference does the psilocybin assisted psychotherapy make to them? And thinking back to the phenomenology, when we think about the life world, we're thinking about 5 particular, what are normally referred to as existentials, but it's very much to do with everyday experience. What do we experience every day? And actually, we're always having an experience of our bodies, of relating, how we relate to others, of ourselves, the passing of time and the feeling of space around us, not even if we're not actually actively thinking about it at the time. And so I'm going to do a longitudinal interpretive phenomenological analysis. And I'm using this particular method because it very much brings into play the Heideggerian kind of hermeneutic idea that you can't separate someone out from their world. You have to, you can only really look at individuals in their world. Otherwise, you're losing something of the truth for that person. And also I'm using this particular method because it has an established longitudinal methodology. And I want to interview 8 people at time 1 before randomized dosing, time 2 after randomized dosing, and time 3 after open label dosing, using semi-structured interview schedules, which I'm just in the process of developing. And I'm also co-designing them with someone on our steering, a participant who's a previous participant from psilocybin and depression trials, who's on the steering committee. And this is, I've also been doing training on IPA methodology, and it's very important for the schedule to be well designed in order to really get good information back out. And it's also important that the technique which I use in the interview is also good, because you're basically trying to get someone to talk freely about their experience with very limited talk from myself, but I'm trying to facilitate them to say these things. And obviously I'm hoping to get people from different, socioeconomic backgrounds, and it's this kind of talking about these kind of things will be more difficult for some people. And then this is the questions for time 2. And then for time 3. And obviously after these questions, after people have been speaking, I'll be using prompts, but it will be very much, I'm interested in the things I've said, but also I want to allow for other topics to come out, from the people themselves. So I will finish there. I'm trying to hopefully going to start the interviews very soon, because we've started dosing on the CIDR now. And thank you very much. And I'm so sorry about the beginning. Many thanks to Mental Health Research UK, to Claire for all her help and support, and to my supervisors, and also my research team at King's.
Thank you, Camilla. Could you just take down your screen share? Can I Okay. I suggest that if anybody has any questions for Camilla, could you put them in the chat? And then Camilla, perhaps you could respond in the chat to the questions. Is that okay? Okay, thank you. And sorry you had such issues at the beginning. I know it's quite difficult on different machines. So let's go on to Kate Bailey. Kate, we have, is Dr. Nicholson here to introduce you? I can't see him on my small screen.
I'm not sure. I think Dr. Poole was hoping to make it, but perhaps not. Happy to introduce myself.
Okay, I will leave you to introduce yourself then, Kate. Thank you.
Thanks. I'll just share my screen, hoping to not have the same issues because I'm on a Mac as well. Can you see that okay?
Yeah, that's fine. Absolutely.
Cool. So my name's Kate Bailey. I'm a consultant psychiatrist. I've fairly recently finished my training. So also congratulations to Camilla as well with that. So I work clinically in East London, largely with older adults, but also in liaison in the acute hospital. But my research is looking at something kind of allied, but slightly different. And I'm looking at the experiences, understanding and conceptual models in people who have functional neurological disorders, and I'm doing a mixed methods study. I've got many collaborators and supervisors who are kind of listed below. I hope one day that this slide won't be necessary, but I think for now it very much is, because functional neurological disorders are something that many people haven't heard of or don't necessarily understand particularly well. I would add that it's FND Awareness Month actually in April, so if you're interested, please check out the FND Hope website and a blog that I wrote for MHI UK this month on FND and some of the challenges that people experience. But FND essentially is neurological symptoms which are not caused by neurological disease, so not a particular lesion or a stroke or something like that, but they do have distinct clinical features and symptoms, and they're essentially caused by a problem in how the nervous system is functioning rather than a lesion. Exactly like I mentioned. So people can experience things like seizures, tremors, paralysis, numbness, cognitive problems. And these are really common disorders that account for kind of up to about 16% of neurology outpatient visits. It's as common as MS. But what people experience is very long delays to diagnosis, very negative experiences with healthcare professionals, and often kind of a sense of sort of hopelessness and being abandoned. So we know that people with functional seizures and weakness often feel that their illness is kind of very mysterious, is going to be permanent. We know that stigma is higher in those with functional seizures compared to epilepsy, and that's quite a striking finding because epilepsy in and of itself is quite a stigmatized disorder. And a recent study from FND Hope found that a very large proportion of people had felt dismissed or disrespected or not believed by healthcare professionals. People often feel very dissatisfied with the explanations they receive. They feel very powerless and abandoned. But like with many other disorders, getting the right diagnosis early, having kind of good care, high satisfaction is associated with a positive outcome. And like anything, understanding what's going on with your body and having a name for it is very important. So St. George's, where I am conducting my research, offer a novel multidisciplinary education session, which early studies that they've done has found that it's increasing understanding, hopefulness and belief in treatability. And that's a session that takes place now online a few times a year with kind of a psychiatrist, a physiotherapist, a neurologist, expert by experience, a psychologist, and goes through some of the kind of explanations and talks about what people can expect from treatment. So my study then is looking sort of at a number of different things. So one part of it is to look just at the kind of lived experiences, understanding and conceptualization, how people understand their illness, so people with FND. And a secondary aim is to look at how people experience attending this education session. So you know, how do they experience the explanations that they're given in that session? Do they kind of land well? Do they make sense to them? So it's very much a exploratory and hypothesis generating study. So like many people, things were quite derailed by COVID, but the progress that we've kind of made in the last sort of year or so has really been that we've adapted everything to kind of an online study, and that brought its own kind of ethics related issues, but we received ethics approval in kind of late November last year, and have kind of gone headlong into recruitment now. So things are moving, which is exciting, I think, after such a long delay. So there's lots of different parts to this study. I'm going to focus on a couple of them today, but we're doing a systematic review of qualitative literature which looks at the lived experience of motor and sensory symptoms. And the focus on that is because much more work has been done previously on experiences of functional seizures compared to the kind of motor symptoms. And that's been, the protocol's been published on Prospero. So we're working on that alongside, because that's also going to inform some of the qualitative work that we're doing. We're going to be doing some in-depth interviews looking, using phenomenological analysis like Camilla's study, looking at the kind of lived experience of these symptoms. And we're also doing a quantitative study, which I'll talk about shortly, as well as a think aloud study like Kerry mentioned with her study of suicide experiences. And we're also doing some focus groups. So lots of things happening in parallel, but the things that we're focusing on mainly at the moment are the quantitative study, because that's very much linked to the education sessions. So we had the first this year in January, where we were able to recruit some people from that, and there's one coming up in May, so lots of work in trying to recruit people for this at the moment. And what we're looking at is just any people with any type of FND who are going to be joining online for the session. And we're asking them to fill in some online surveys before, immediately after, and a month after their session. And we're trying to capture kind of illness perceptions and experiences, mood, measures of their functioning and disability, and also focus on stigma and trying to kind of understand that from a number of different measures. So talking about the illness perception questionnaire, so we know that illness perceptions and kind of people's beliefs about their illness, their perceptions of the hope for treatment, whether their illness can get better, or and what sort of sense they have of control over their illness is really important in terms of recovery and engagement with treatment. And the IPQ has been used in lots of different physical and mental health disorders since it was sort of created 20 years ago. So one of the things that it looks at is kind of illness representations based on the Leventhal's common sense model of self-regulation, which is just a way of kind of understanding how illness affects the self and kind of the body. It is sensitive to change, so that's one of the reasons that we're using it, and also because a large systematic review looked at the kind of outcome measures that would be important to measure in FND, and illness perceptions was one of them. We're particularly looking at stigma as well, which is a kind of novel aspect of this study, because although kind of subjectively, and I guess the reports from lots of people and studies that look at healthcare professionals have shown that there's lots of kind of negative interactions that occur, and that stigma is a very, very big problem in FND. I don't need to really explain too much about what stigma is to this group of people, but I guess one of the things that we know is that it exerts a very powerful influence on clinical interactions, and that there's also an aspect of stigma that affects not only kind of the discrimination and kind of systemic issues, but also the sense of self and kind of how people feel about themselves. So we're using a measure, the SSCI-8 which looks at enacted and internalized stigma. So the enacted stigma is kind of what have you experienced that is stigmatizing, and then the internalized is kind of how has that then affected you, how have you incorporated that into your sense of self. And then a further aspect of stigma is the CIASS, which looks at kind of then what do you then anticipate in the future in terms of interactions, because we know that if you've internalized something or had lots of negative experiences before, then you will obviously go on to expect those in kind of future interactions. So asking about, you know, what do you expect, how do you expect healthcare professionals will treat you? So we're looking at all those different kind of aspects of stigma. And in terms of the Think Aloud, which is a methodology that I kind of only came across in the course of developing this study, and actually kind of arose from feedback from FND Hope, so the charity FND Hope, who looked at our protocol and sort of highlighted that some of the questions, particularly in the illness perception questionnaire, might actually be a bit problematic for people who have often had experiences where they've been dismissed by healthcare professionals or kind of perceived as if they were malingering. So some of the questions were highlighted as potentially offensive, but also there's also a body of literature looking at the need to actually adapt the IPQ to make it much more sensitive and appropriate for particular disorders. So these Think Aloud techniques have been used to do that with things like atrial fibrillation and diabetes, to adapt the IPQ to make it more kind of sensitive and appropriate. So we've added this aspect in, and we will be taking a subsample of participants and doing Microsoft Teams interviews with them, sharing a screen and going through the survey together, where they kind of literally just talk through what they're thinking as they're doing the questions. And I guess we've done a couple of interviews so far, a couple more coming up. I guess I would say it's very illuminating already, sort of as a kind of adjunct or to understanding how questions are interpreted. People really often get very different things from questions than what you would intend. As a kind of example, with one of the stigma questionnaires, one of the participants rated anticipated stigma very low for employers. And that was kind of a little surprising in a way. But as they talked more about this, that was because they had no intention of telling their employers about their illness. So just a kind of one example of how the questions can kind of be interpreted in a way that might kind of falsely give different results. So really interesting methodology. I'm looking forward to kind of continuing to use that. So that's where we're at the moment. It's sort of full steam ahead with recruitment and getting to sort of very much more the interesting part of the study now. It's not theoretical anymore, it's actually happening, so that's nice. And thanks as always to MHI UK for the support with this. And that's the link to the blog for April FND Awareness Month. Thank you.
Thank you very much, Kate. That was really fascinating, because these are a truly abandoned sort of group of individuals with FND, or they certainly feel abandoned. So really interesting. And I would urge people, if you haven't read the blog on our website, it's really interesting and very good. We've just got time for maybe one or two questions. Right, is anybody? I can't see any hands raised at the moment. Can you just to start off, can you just describe, is it difficult to recruit the patients for your study, or have you found it very straightforward? Are people reluctant or not?
I think what I've found is the survey has been a little bit tricky. We're sending out kind of email invites along with the education session, and that's been kind of sort of, yeah, getting, I suppose, sort of the first time around, like kind of 25% or 30% kind of response rate. whenever we contact people by email, there's kind of issues with emails getting lost and that sort of thing. In terms of the people I've spoken to about the Think Aloud study, people are much kind of keener. So when we have a phone conversation, I found people kind of very enthusiastic to kind of help. And most of the responses have been, you know, really glad that someone's doing some research into FND. So it's sort of a mix. I think that the personal response and having a phone conversation often works a lot better.
Yeah, thank you. Camilla, you've got a question.
Thanks, Kate. That was a great presentation. I was just wondering whether in your research so far you'd had any crossover with long COVID at all. Just wonder what your experience of that is.
I think there's definitely a lot of crossover with long COVID. I haven't sort of looked particularly at, I suppose, much except kind of picking up what's going on kind of generally and how the experiences of people with long COVID very much kind of mirrors the experiences of kind of chronic fatigue and other sort of illnesses that are contested within the medical community, and the kind of importance of kind of people with lived experience actually driving research agendas, because I guess that's one of the really exciting things about long COVID research, and that the kind of groups like the Body Politic and things like that kind of highlighting from the very beginning, sort of, and getting people to take notice. I think there's going to be a lot of sort of overlap, and certainly my supervisor Tim is actually involved in setting up kind of long COVID clinics and so on. I guess the thing is always with these sort of conditions is trying to learn from the mistakes that have gone before with illnesses where people, you know, as healthcare professionals, we don't understand, and the risk is kind of dismissing people, and that tends to happen kind of time and time again. So hopefully we can do things better this time around.
Thank you. Thank you very much, Kate. That was a really great presentation. So the last presentation is from Nuala Kane. And I made a mistake earlier, that it's actually Nuala who has the Tom Palmer Award. Nuala is due to submit in May and has just come back from an NIH travelling fellowship, which must have been very interesting, and has a consultant post now in Dublin. And we wish her lots of luck with that. Nuala, would you go ahead and do your presentation?
Thanks very much, Claire. Can I just check that people can see my slides okay?
Yes, that looks fine.
I'm also on a Mac, so I was also panicking when Camilla was panicking. Thank you. Yeah, so this was my final Scholars Day. So my project is working on difficult and contested capacity assessments, and it really, so my interest in this area really came from my clinical experience, particularly in liaison psychiatry, but I think across mental health, we do assess capacity more and more, and sometimes it can be tricky. And I suppose I was really interested in getting to the bottom of why it's tricky sometimes, and what can we do to help clinicians who are approaching these difficult capacity assessments. And yeah, as Claire mentioned, so I was awarded the Tom Palmer MD-Res scholarship in 2018. So just to give a sort of overview, so my work is really focusing on how capacity assessments happen in practice. And in England and Wales, the Mental Capacity Act is the legal framework which sort of governs how we do capacity assessments. And I'm interested in capacity assessments in practice in different types of practice. So you'll see on the top left there's a picture of the High Court. So the Court of Protection, including sort of High Court judges, oversee capacity assessments when they're sort of escalated to court level. So I was interested in court practice, but also in hospital practice. So in the general hospital setting as well, where capacity assessments are frequently carried out in relation to capacity to consent to medical treatment or discharge decisions or social care, also in the context of discharge. So again, I'm interested in sort of how, you know, we have the black letter of the law, but how is this actually applied? How are the capacity criteria applied, and what are sort of those who are assessing capacity actually doing in real world settings? And just sort of, or maybe I should briefly say just an overview. So today, so I've done 3 studies as part of this, as part of my MD Res. The first 2 studies were the court studies, and the third study, which I'm going to speak more about today, was a study in relation to the medical setting. So just briefly, the 2 court studies, which I've presented on previous Scholars' Day. So the first one was looking at disputed cases in the Court of Protection, so looking at what really are the characteristics of cases where there's disagreement about capacity and how the judge resolves those cases. And then the second court study was looking at a large body of judgments from the Court of Protection, and looking at how judges and expert witnesses, who are often psychiatrists, how they actually justify their capacity findings, and making a sort of typology of the kind of reasons that are given, or the kind of decision-making abilities that are cited by the judges and by the experts. But the third study, which I'm going to talk about today, is an interview study. And in this study, I interviewed liaison psychiatrists who practice in the general hospital and are often seen as the sort of capacity experts. So if a surgeon, for example, is really struggling to figure out whether a person has capacity to consent to surgery, they might ask the liaison psychiatrist for a second opinion. And so just very, very briefly, because I know not everyone is familiar with the capacity law, the Mental Capacity Act has a definition of what it means to lack capacity. And it says that a person lacks capacity in relation to a matter. So it's always a specific decision or specific matter. If at the specific time, the material time, he's unable to make a decision for himself because of an impairment or a disturbance in the functioning of the mind or brain. And this idea about being unable to make a decision is further sort of specified as an inability to understand, retain, use or weigh relevant information, or an inability to communicate that decision. So that's sort of what the practitioners are putting into practice essentially when they make an assessment of capacity. And so to talk about the interview study, so this, I sort of wanted to focus on the findings or the results. So I've just I'm going to just speak very briefly on the kind of protocol that we used. But we wanted to speak with liaison psychiatrists because we know that they're these capacity experts in the general hospital. And sort of the background of this was, we know sort of clinically that sometimes capacity assessments can be tricky, and this is talked about sort of in the theoretical capacity literature quite a lot. So philosophers and lawyers are fascinated by sort of capacity assessments and how they can be difficult. But there's very limited sort of research studies looking at what's actually difficult in practice. This is just 2 studies based in Switzerland from a single sort of interview study there. And they picked up that sometimes with sort of more complex medical or psychiatric conditions can be tricky. Sometimes if cognitive impairment is fluctuating, for example, or if they're really high risk decisions like sort of a life-threatening medical decision, or, you know, where it looks like somebody might, you know, where the decision is about somebody moving to a new living environment, to a nursing home, for example, that those can be particularly difficult. But we don't have any information on how people actually deal with those difficulties in practice, how they resolve those cases. So the aim in my study was to describe how these experienced liaison psychiatrists, to describe their sort of self-identified hard capacity cases, so the cases they thought were tricky, and how to resolve them in practice. And the way I did this was to interview 26 liaison psychiatrists across 3 countries. And the idea was that then the difficulties wouldn't be just specific to legislation, but they'd be really about sort of the difficult cases in practice rather than sort of vagaries of the law. And then I analysed these using thematic analysis. And I've picked out, so these are the 4 main themes that came from this analysis of the interviews. So the first was where the psychiatrist had difficulty whether the person's decision was really their own, whether it was their sort of true decision, or whether it was driven by some kind of mental illness. The second was, and I'll give examples of these, the second was where they had trouble in applying an ethical principle, so principle like autonomy or wanting to promote somebody's welfare. The third was where they felt there was difficulty in avoiding personal bias or professional bias. And the fourth where there was some kind of procedural difficulty, so difficulty in actually carrying out the assessment itself. And I'm going to give sort of one example of each of these, but I'm again the paper is shortly to be submitted, so I'm very happy to circulate if anybody's interested or to answer any further questions about the results. So the first one, so the difficulty in determining whether the decision is the patient's own or driven by illness. And one example here was sort of hard cases which came up where the psychiatrist was really struggling to figure out whether there was some kind of delusional belief driving the decision, or whether in fact it was the person's own decision and just, related to sort of cultural factors or religious factors. And an example that was given was of an elderly patient who was refusing painkillers, and he was saying that this was for religious reasons, and he was in, he was suffering, he was in quite a bit of pain, and the doctors were really worried, and they thought, does he have a psychotic illness? Is that the reason why he's refusing? And is it some kind of a religious delusion? But the psychiatrist who saw the patient was able to sort of find out more about this person and, what their life history had been. And actually they'd been sort of staunchly religious throughout their life and had very strong sort of beliefs. And these had even intensified towards the end of, or as this person got older. And the psychiatrist even got a Catholic priest to come in and speak with the patient to sort of check whether this really was, a decision that was in keeping with his belief framework, and they felt that it was, and they felt that actually he did have capacity to refuse to accept painkillers for his pain. And the quote that's here is from a different case actually, but it's this idea that sometimes it can be really hard to actually pick out if there is a mental illness causing the decision, if there is a delusional belief, or actually if this person maybe just has a belief that's different from the psychiatrist's belief, but nonetheless very understandable in the context of their own history. And there were sort of various different illness factors that could be relevant, but this is just the example of a delusional belief, or a not a delusional belief, as this case turned out to be. So the second main theme was looking at difficulty in applying ethical principles. So kind of less clinical, this one. And the quote that you'll see there, it's sort of about the driver, the ethical duty to protect the person's welfare. And psychiatrists said that, they're more likely to be called where the stakes are really high, where it's a life and death decision. And in those cases, you really don't want to be casual about how you assess someone's ability to use and weigh, because you don't want to be too coercive, but then at the same time, you don't want to let their life slip away because you've made the wrong judgment. So psychiatrists here were really grappling with this idea that if the decision is very high risk, so if the patient is refusing a treatment that's life-saving, for example, does that change how they do the capacity assessment? And some felt that actually it should change in terms of the threshold for capacity, so that actually you should be, if the risks are high, you should have a higher threshold in terms of using weighing, so that the person really needs to be able to use and weigh the sort of nitty-gritty of these high risks. Whereas, if the decision was a lower risk decision, that they wouldn't need the same sort of threshold of using weighing ability or the same threshold of understanding. So some psychiatrists felt that that was the case, you shifted the threshold, but others were really worried about this, and they felt, well, given that we're supposed to presume capacity, is it fair to sort of put a higher burden of capacity on these people just because they're making a higher risk decision? And other people looked at it a bit differently. They said, well, maybe it's not the threshold that's shifting, but actually I need to find more evidence that this person has capacity, or less evidence that this person lacks capacity, or I need to do a more intensive assessment. I really need to work hard to make sure I'm getting things right or getting as accurate as possible in assessment. So there were sort of different ways, but people sort of differed and struggled and grappled with the ethical implications there. And the third theme, so again, sort of an ethical theme, was difficulty in avoiding personal bias. So psychiatrists really spoke quite candidly about the sort of personal drives that are the person, the things that go through their mind when they're doing a hard capacity assessment. And they spoke about how difficult it can be sometimes to see a person who's making a decision that's going to let their condition deteriorate. But they said it's also really difficult to see somebody be overruled and be subject to restrictive medical treatment, for example, coerced to have medical treatment that they don't want. And they spoke really about the emotional toll that can have. They also spoke about even more personal factors, so feeling really worried that if their patient came to harm based on a decision that they took, then actually they could be criticized, or they could be, sued even, if that were to happen. So some spoke about their own sort of political political values and spoke about how, you know, they felt that they were a libertarian or they really valued autonomy, for example. And others kind of thought about, you know, the medical profession, and they sometimes contrasted the medical profession with social workers, and they wondered if medics were more likely to find somebody to lack capacity in a borderline case because of maybe, you know, this kind of caring instinct or wanting to do something, or maybe being more aware of, you know, untreated illness, what grisly consequences that can have. And psychiatrists were really open and sort of candid and reflective about the kind of biases that could come into play in difficult capacity assessments. And they were really sort of, you know, many of them showed a great awareness of, you know, the dangers of sort of applying their own values to the values of the person and saying, well, just because this person is making a decision that I wouldn't make, you know, according to my values, it doesn't mean that actually they lack capacity. And that's very much in keeping with the spirit of the MCA, which says, you know, people should be allowed to make unwise decisions. So psychiatrists really advocated of being sort of aware of one's own values to ensure that you don't impose them on somebody else in a capacity assessment. And finally, so this was again a more clinical area of difficulty. So in terms of the actual sort of procedure of the assessment itself. And one example that came up quite a bit was where the person didn't want to engage in the capacity assessment, and how this was really sort of difficult for the psychiatrist. And sometimes the person would engage with the assessment, but they'd only engage in a limited way. So there was one example of a person who, I think it was a patient who was suspected to have depression, who was refusing renal dialysis. And the psychiatrist was assessing him, and the person was saying yes, no, yes, and it was all sort of one-word answers. And the psychiatrist felt that the patient kind of knew exactly what he was trying to do in terms of assessing for depression, and just wasn't really interested in giving any information to the psychiatrist. And that was really difficult. And there were sort of other examples where the psychiatrist was really trying to grapple with whether the person wasn't engaging for their own reasons, or if actually they were unable to engage. And there was an example of a woman who had a very severe schizophrenia. She was quite thought disordered. And whereas superficially it might seem that she's just being dismissive, actually, when the psychiatrist saw her repeatedly and sort of spoke with people who knew her, was able to figure out that actually this person really wasn't able to engage. They just had poverty of thought. They couldn't sort of grapple with the information. Their thinking processes were restricted because of the psychotic illness. So what psychiatrists really found helpful in these cases was to work hard to build rapport. And sometimes that involved, you know, bringing somebody else in, somebody who the patient had a good relationship with, doing multiple assessments. And where it wasn't possible to engage the person at all, sometimes the capacity decision had to be made through observation, through involving other people. Yeah, so I guess just in summary, sort of the findings that we had, so the conclusions that we made were that you need both clinical skills and ethical skills in hard capacity assessments. We found that these sort of experienced assessors are aware of the kind of pitfalls that you can make, like sort of adhering to personal bias, for example, and that psychiatrists who do a lot of capacity assessments have developed lots of creative strategies to resolve hard cases. And we hope that they can be that summarizing those strategies can be useful for other people who are approaching hard capacity assessments. So that's sort of the interview study. I guess just briefly to mention from last year, so the court, so I published from one of the court studies, and there's been a second paper on that as well. And the court study also has contributed to capacity guidelines, which are available online. And as Claire said, I was lucky to be able to go to the National Institutes of Health in the States and to work in a bioethics department. That's a picture of me with the cherry blossoms behind me. And that was really, because I'm just so interested in mental health ethics, and it's really sort of at the core of my research. So it was great to get some different perspectives over there. And just again, the capacity guide. So this is a publicly available guide for clinicians or any social workers, anybody who's doing capacity assessments. And my research, my court research, fed into the part about understanding the functional criteria. But I'm also hoping that the interview work, you know, looking at specifically at hard capacity assessments in a medical setting and how people resolve them, I'm hoping that will be sort of another section on this guide, which is going to be evolving. So thank you very much. Thank you so much to Mental Health Research UK, who've supported me over the past 4 years, to my supervisors and to the family of Tom Palmer. I think Judy's here today. Thanks so much. I mean, it's been great, and I'm a bit bittersweet to do my final Scholars Day, so much appreciated.
Thank you very much indeed, Nuala. That was so interesting. Absolutely fascinating. And I think for me, seeing the outcomes of the work that you've done, and the capacity guide, and that the fact that that's going to be a kind of evolving resource is just a really good example of how research can translate into something with real practical application. So absolutely great. Thank you. So are there any questions from anybody? Well, just in the last couple of minutes, are there any general questions that anybody would like to, are there any general questions about the MD-RES and so on that anybody would like to hear more about? I mean, I guess that I will ask a question, and any of you can respond to this. I mean, it seems to me that that it is extremely demanding to do to carry out this research over a number of years while you have really demanding clinical commitments as well. And I just wondered if one of you would like to say something about that experience of balancing the research with your clinical commitment.
I can start. I'm sure others have things to say as well. So I was lucky in that I had a funded year to do my data collection. So that was on a larger project, but I think that was really helpful for me. I think the other thing that was really helpful is we're so lucky in psychiatry training to have a day a week to devote to a special interest. And in my case, that was research throughout my training, or my higher training at least. So that's how I've been managing to do it. And I think there's real benefits to doing research alongside your clinical work. So I think I know you spoke about sort of real world applicability. I think like that's what I want to see, you know, because I'm a clinician, and I'm keen to see like my work actually have impact in clinical practice. And I think you really maintain that drive and motivation by doing your clinical practice. But yeah, it's not easy is the other thing I'll say, and you certainly have to learn, and it's things I probably learned by making mistakes, but by trying to be sort of boundaried around your time, and trying not to take on too much, and learning to say no and all those things. And I think those are things you learn by doing them completely wrong, and then sort of realizing that you can't do it that way, and you need to be more boundaried, etc. So I don't know if others have similar experiences.
Camilla.
Yes, it's a really good question. I just like to also incorporate also having 2 young children, and sort of taking maternity leave combined with that. So yeah, the three things. I think, yeah, it definitely is I think perhaps a struggle. And oh no, we're going to finish very soon. But that's why I've invested so much. I'm applying for this job as a consultant, where I've been talking to them, and they say that there's a possibility of basically me having 2 days research a week. And this is what I'm really going for at the moment, to really have those days set aside, where I can continue doing this research, you know, on the same day, and it'll be the same job, and everything stays the same. And that stability, I think, will really help juggle the 3 things.
Thank you. Well, have you got one word to say, Kate, right at the end?
I think just, yeah, the future, I guess, is trying to find job plans where it's possible to do both, because I think it's very nourishing to be able, and helps with sustainability, to be able to have different things. So definitely. Yeah, anyone's out there thinking about consultant job plans, putting in time for these kind of things is great. They both feed off each other.